Hello, everyone. My name is Dan Choi. I am the Young Physicians Section Chair of the Medical Society of the State of New York, and welcome to our weekly podcast webinar on adjusting your practice to COVID-19. And we have a lot of distinguished guests today on our podcast. And first off, coming back to our webinar from weeks prior is Phil Hsu, Executive Vice President of MSSNY. We also have Tom Medeski, past president of MSSNY. And joining us today is Dr. Dan Gold, who is a otolaryngologist in White Plains, New York, part of ENT and Allergy Associates. And we also have our colleague down from Texas, Dr. Greg Fuller, who is a family medicine physician in a single specialty group in the suburbs of Fort Worth, Texas, joining us. And also from our law firm that Garfunkel and Wild, we have two of our distinguished attorneys, and they are Sal Pucio and Lauren Levine. Sal and Lauren are partner in the firm's employment and litigation practice groups. Sal and Lauren advise clients on a wide variety of day-to-day employment counseling, contract disputes, disputes with payers, and real estate matters. In these challenging times, Sal, Lauren, and their colleagues at Garfunkel Wild have been assisting physicians and healthcare providers with staffing concerns, navigating the newly created sick and leave laws, telemedicine expansion, and analysis of the CARES Act, including eligibility and criteria for participation in the Paycheck Protection Program. And today they'll be able to provide us with some brief updates regarding all of the recent developments. So I'd like to start off with Dr. Medeski for him to walk us through a chart that briefly looks at projections of kind of the financial downturns that practices are expected to be hit with in the coming months.
Thanks, Dan. Projected in front of you is a graph that makes some approximations of what's happening with practices. And we're going to have for you different representations of that today with Dr. Fuller, who's in a family medicine group, talking about how they're trying to bring things, keep things online and keep their practices open. And Dan Gold is going to sort of talk with us about it from a specialty standpoint. But as we've talked about on the previous cases, you're able to do some business with telemedicine, but most cases it's not going to be to the level you had when you had your practice fully open. You have less practices, patients coming in. Even with primary care, there's procedural things that generate some additional ancillary revenue, and that stuff is difficult to generate with telemedicine. So there's a nice newsletter called GIST Healthcare, which you can get for free, which gives some information on a weekly basis. And one of the principals there did some projections looking at what happens to cash flow. And that's shown for you here on the graphic. And you can see where you have the loss of inpatient revenue. You're doing some augmenting in terms of the telemedicine revenue. But you're still not going to be able to maintain yourself whole without doing other things. And that's the point of our discussion today. So with that, Greg Fuller, who's a friend of mine from Texas, and we've worked together at the American Medical Association for a number of years on socioeconomic issues, is going to tell us about how his practice is approaching it. So Greg, if you would hop on.
All right. Thank you, Tom. And howdy, y'all in New York. Our thoughts and best wishes are with y'all during this devastating time in New York and the New Jersey area. Our group of independent family physicians, we have 5 physicians, 1 nurse practitioner, and 3 PAs, 2 offices. And then we're part of a larger group called Catalyst Health Network. We have about 700 primary care physicians in the DFW area and some in East and West Texas. So the graph that Tom just showed is very germane to what's happening to primary care when we run a 70 to 80% overhead, and unfortunately in the fee-for-service world, it's all a volume-based business. We do some procedures, we do some ancillaries, but really the majority of our finances come from office visits and seeing patients. So our group had not done telemedicine yet. We talked about it over the last couple of years, and our larger network was having some discussions about could we roll that out to the bigger network. But very quickly, we saw that we were going to have to go to telemedicine. So we began with several different platforms to use, and very quickly ramped that up. Currently, I'm probably seeing about 50% of my visits through telemedicine. I still see live patients in the office. Fortunately, in our area, we don't have a lot of coronavirus activity, but we're being very judicious about who we're seeing in the office. We're dedicated a couple of exam rooms for healthy patients only. Anybody with any fever or respiratory symptoms, we're doing telemedicine visits with them. We also knew that volume was going to be an issue, and so very quickly we saw 50 to 75% reduction in visits of any sort. And so what we did, we converted a lot of physical exam visits to medicine check visits. We do have lab available for a lot of those patients, and we ordered lab and told patients to go in and get lab ahead of time if possible. My practice is also open earlier in the morning and later in the evening, and that volume has somewhat decreased, but still we get some after hours business. We're also open on Saturday and Sunday, and so we're still seeing some volume of business on the weekends. Another thing we did was to go into our EMR, pull up our patients from 6 months ago, and have pulled up all those patients to look to see who's due for a med visit, who's missed a med visit. And our front office staff have been working those lists to bring those patients in, and that's been pretty successful. We're still seeing new patients. I've done a couple of new patient visits, telemedicine visits. I've still seen new patients in the office. Interestingly, I saw a patient today who got hold of us because he'd called several clinics in the area and said they weren't seeing new patients until July. And I'm assuming those are probably hospital-owned practices that have done that. He didn't know for sure who they were. His wife had arranged the visit. On the other side, we're looking at expenses, and we know employees are our highest expense, and so we have furloughed several of our employees to help lower our cost. We run a very lean practice anyway, so we didn't really have to furlough that many people. So we're all hands on deck. We're anybody calling in, as I have joked this past month, over in the before we did telemedicine, I would always say, dang it, that person calling in, that's a telemedicine visit. We need to be doing telemedicine. So now it's easy to do. It's a telemedicine visit. So that has been a good thing. And of course, there's no going back now. It's just, I think for the future is going to be right now, payment is all our commercial Medicare business is paying for telemedicine. I think the thing that's going to be interesting is once this settles down, are we going to go back and have some controversy with the commercial health plans who already have some telemedicine platforms that we're not part of? We have pushed in our Texas legislature to have equity regarding telemedicine. So we'll see how that all plays out in the future. We're also in our larger network, we're having a direct conversation with all our commercial health plans every week, and we have really ramped up our discussions about value-based medicine and prepayment care, or capitation is the old term, because I think this is coming, and there's been a lot of discussion from primary care, especially the AAFP, about the Marshall Plan. You will see a lot of discussion about that out on social media, about how primary care is going to have to change their payment model.
Yeah, I think that is a worthy discussion, but for another day.
Yeah.
So thank you, Greg. That was really helpful. Some of the other things we've done in our primary care group in terms of trying to augment visits, because as you said, it is very much a very volume-based thing. We are able to use some of the codes now to follow COVID patients. We have more of that up here, obviously, and we have a daily check-in, and we're generating some revenue off of those things. I think one of the other things you can look at in your practice is, your routine visit scheduling. So I have stable workers' comp patients who, I see probably a couple times a year, but who are getting narcotics, things like that. We have very good screening and stuff for that, but there's probably ways to leverage that appropriately to help with some of the deficit. If you have outside areas where, you have patients coming in, like adult care or nursing facilities, we have that ability too, and that actually has helped to offset some of the loss that I've had in the office.
Okay.
Let's, for a different perspective, let's go over to Dan Gold, and he can tell us what they've done at ENT and Allergy Associates. You got to come off mute. There you go.
Yeah, unmuted. Okay, so I guess a little different perspective in a subspecialty world. So a little bit about ENT and allergy. We're 46 locations, 46 offices throughout New York, New Jersey. We're 220 doctors, both ENTs and allergists. So our offices are providing adult and pediatric ENT and allergy. We have subspecialists in our office who specialize also in ENT. We have diagnostic audiology, hearing aids, sleep, CT services. So we have a lot of stuff going on in the office, but most of the stuff actually requires patients to physically be there. We also have alliances clinically with a bunch of the major hospital systems surrounding us. Sinai, Montefiore, Northwell. So we're sort of hooked into what goes on around us. And there's a lot of exchange of patients through the systems. So our story, very similar to what Dr. Fuller had talked about. In late March, we began to recognize that our office buying was down about 80%. We had stopped major in-office procedures and all OR-based surgery in early March. As we're all aware, New York State came down with a directive essentially asking all elective procedures to be postponed. We're also in a specialty where our procedures are considered some of the highest risk. We're in the mouth, we're in the nose. This is an aerosolized virus. So we had to limit most of our office endoscopies, and that's one of the foundational procedures of our practice. So it's kind of hard when we can't scope people. So essentially, we closed 39 of our 46 physical locations sometime towards the end of March. Along with that, we had to furlough many of our staff over the last few weeks. This was both clinical and non-clinical staff. However, we did maintain sort of a core group of staff, both clinical and non-clinical, to allow some regional offices to stay open. We kept open 6 regional offices, spreading from New Windsor to Hauppauge. We're here in White Plains. We have a Fifth Avenue office, and then one in Queens. So we pretty much all over the map, and I think Shrewsbury also. So we're also, we have a mid-Jersey office as well. And then to support our telehealth. Again, telehealth, we had no precedent for it. In ENT, there really isn't a great use for it in our specialty. Mostly was used for post-op visits, for checking on wounds and stuff like that. So we had to launch the telehealth platform from scratch, essentially getting 240 clinicians on board. It took us about 4 days. We got everybody on, we used a single platform, and so everybody was sort of seeing patients. Right now, we're only seeing established patients. It's a little harder in a specialty practice. New patients, there's just a lot of back data necessary for it. But we're currently seeing 900 virtual visits a day, and mostly through that single platform. We have to switch a lot of our advertising, so people in the New York area know ENT and Allergy likes to advertise. So a lot of our social media, our marketing to support the telehealth away from our physical offices. We're seeing only a handful of physical patients a week. Most of these are emergencies, things that can only be done. Foreign bodies, nosebleeds, airway issues, things that we really have to be, manipulate on to be able to. Everything else we're trying to do through telehealth. But as we know, telehealth is really a poor substitute when you're in a procedure-based specialty. A lot of areas that we can examine, it's really hard. You ask someone to shine a flashlight on their throat, and there are shadows. I don't know. Is that a shadow? Is that a piece of mucus? Who knows what that is? So we're pretty limited. And so we feel like we're doing a service for our patients to stay connected to them, but we're really not providing as good care as we'd like to provide. Fortunately, a lot of our doctors got on board early, and we have a spectrum of doctors among the 220, from ones who are just out of residency to doctors who are in their early 70s, who are getting close to retirement. But the majority have pitched in. Limited compensation for doing this because we essentially shut down most of our compensation mechanisms. So volunteer staff, staffing the offices for emergencies, triaging phone calls, performing the telehealth visits. And we're just trying to remain engaged, trying to remain accessible to our patients, whatever we can do. Like most practices, obviously the financials of it are very difficult. As Dr. Medeski showed at the beginning, with 80% volume down, that means that revenue is significantly down. So we spend a lot of time and a lot of work shoring up capital reserves, our lending partners, getting grants to whatever we can do to make sure that we're ready to restart operations. We also spoke to our landlords to talk to them about what we can do in terms of deferring rent and figuring out ways there, trying to make our operations as lean as possible, but keeping everything in place so that we can spin things up once it becomes safe in New York and patients feel comfortable coming back to us. Obviously, the big thing has always been how do we determine when do we come back? And at this point, it still looks like not much is in the tea leaves. We're waiting for available COVID testing, reliable immune titers to help guide us to there. Even when we come back, we're expecting to come back in limited capacity. Hopefully, limited capacity May 1st, maybe there. We'll have to come back progressive. We took everything offline in a slow fashion. So initially bringing back just a handful of the clinical staff, a handful of support staff, seeing what the patient volume looks like, bringing people back onto the payroll, taking it very slow. We wouldn't expect, especially for surgical volume, things to really pick up. Probably 4 to 6 weeks out from when we open. I know there's data from other countries where they've lifted restrictions, but the patients are still very wary about coming in to the procedural-based specialties. And I would assume that we're probably going to see a lot more movement in outpatient facilities, the ASCs. I'm guessing hospitals are going to be pretty bogged down for weeks, if not months, before I think we're going to feel comfortable admitting a patient post-op. So at least early on, it'll probably be still a lot of these ambulatory cases in, out, and getting people moving.
So one question I have for you, Dan, we had talked about, you had furloughed a number of employees. Some of them you said had been given at least temporary positions by some friends, other organizations. What's your concern about getting people back when you need them? Are you concerned about that? Or you think with the economy in the tank anyway, you'll get all your folks back?
So right now, the majority of our employees were offered the ability to go to the other health systems. And if you're in the New York area, you know that de Blasio, even the mayor, even said out there that Health and Hospitals Corporation, the public hospital system, is looking for employees for all different things. The majority of our employees chose not to. They chose not to sign up. They chose not to. Again, working in an outpatient, we're not really exposed to infectious diseases except in this way. And that was one of the reasons that the employees and our offices had to shut down. So the people who had to go to work, I think, took up that alternative. But I think the majority of our employees are sort of waiting. Fortunately, New York State had offered insurance, and as well, the federal COVID-19 is getting a lot of our employees through it. I think when you put the two together, it comes out to be enough for most of our basic employees to survive for the month or two until we get things ramped up again.
Okay. Along those lines, let's go to Sal. And Sal, if you can give us an update on the PPP and advances and what else you could tell us there.
No, absolutely. That's a great intro into what we've been helping a lot of clients with. What Dr. Gold just mentioned, we're facing those challenges with our clients on a daily basis. And as a threshold matter, thank you all for having us here. We appreciate the time. So with the PPP program, the Paycheck Protection Program that we talked about last week, some of the questions we're getting now are, okay, I'm ready to get funding, or in a couple of cases as early as Friday, I got funding. What does that mean? Do I have to start bringing back staff in order to meet the forgiveness? When, as Dr. Gold pointed out, you're still not ready to be operational for another 4 weeks at least, and that's a hope. So there are some new questions, and additional guidance came in over the weekend from the SBA in terms of what the rule states is that in order to achieve the full forgiveness, which is 100% of the principal, you have to have your full-time employee equivalent be the same in this period of time during the loan origination as it was in either last year or year period from February to June or February to June of this year. So there are some strict guidelines that have to be followed in order to make sure you don't lose that forgiveness. And it's really several questions with respect to when I bring back my employees and how soon. Recent guidance suggests that if you bring them back by June 30th, you should still be okay in order to receive the full forgiveness. But we're going to be monitoring this very closely because the technical language of the statute would imply that you should start bringing them back now because they have to get the loan is for these payroll expenses. So that's just one area we're looking at with respect to the PPP program. More generally, though, applications are being accepted. It's all across the map with respect to what bank you go to. Chase is releasing funds. Capital One is still not online, or maybe they are as of today, but they weren't as of Friday. So again, it's all over the place there. The other issue that we're dealing with now, that's a real big one, and Dr. Gold just really hit this nail on the head here, is the unemployment issue. So the federal government has come out with certain programs that would provide supplemental insurance to the tune of $600. So many of your staff employees, not your physicians, but the staff, the front office, back office folks, are getting a $600 stipend on top of the $500 or so from the state that they would qualify for. And we've had a couple of folks reach out to those employees that were already furloughed to say, we have some positions available. We want to start doing more telemedicine. Would you like to come back to work on a reduced basis? And the answer from the employees has been, no, I'm making more money on unemployment. So we're now getting the questions, what do I do? And we said, well, the best you can do is offer them the position. If they don't want to accept it, you should explain that, well, we need to fill these roles and we might have to move on. So please be advised, we can't guarantee your job. That furlough might now be converted to a temporary layoff. We cannot guarantee your position because we need you now. And that ties into the full-time employee equivalent that I spoke about with the Paycheck Protection Program. You get your loan in 2 weeks and you want to bring folks back and they're not ready to come back because they like collecting unemployment. Well, you're going to have to look elsewhere to fill those spots in order to get forgiveness. So those are just some of the newest challenges we're facing with respect to unemployment and the Paycheck Protection Program at the moment. And we're going to continue to monitor this because we expect further changes to be coming in the next couple of days and certainly next couple of weeks as well.
Great. Okay. I think we have Lauren talking about some employment issues related to bringing people back and forth. So Lauren, if you wanted to make some comments, please.
Yes, thank you. I just want to touch upon a few of the things. I know the landscape has changed for you as practitioners, and from our perspective, the legal landscape is changing every day. Just one thing I wanted to mention, that the Department of Labor is changing their guidance on a daily basis. We have never seen the Department of Labor, change positions so quickly on issues. And so it's so important to know before you make any employment decisions what that current guidance is. One of the other things that we're getting a lot of questions about now is practices that are still running or practices that are now, contemplating bringing employees back. What can we do to protect our employees other than cleaning and other safety measures that the CDC has recommended? Well, the EEOC has said now that this is, become a pandemic for some time, that you are able to take your employees under normal circumstances you would not be able to do. You can also ask employees if they're experiencing symptoms or if they've been tested for COVID, all things that you wouldn't normally be able to do with respect to, invading an employee's confidential health information. Just a couple of caveats. If you're going to test, you either have to test all of your employees or you need to test just those individuals who you have a reasonable belief has COVID symptoms or has COVID. For instance, if you have an employee come in with a hacking cough, obviously that would be someone that you would want to test if you're not testing the whole staff. Another caveat is you cannot ask these questions of staff that are working from home. If you have people that are doing telemedicine right now and are able to work from home, you cannot ask them anything about their confidential health information. And with respect to employees coming in, you also can't ask them if any of their family members have coronavirus or COVID-19. You can ask them if they have been exposed to it by any other individuals, but the law prohibits you from asking for health information related to a family member. So there's a lot of nuances there, but I think it's going to be a good tool for when employers are trying to bring staff back slowly so that hopefully we can keep the workplace safe. The other quick thing I wanted to mention, we're getting a lot of questions, and unfortunately there's not as much clarity here. We're getting questions about whether workers' compensation will cover COVID related illness. And there's been no guidance from New York State yet on that. The only thing we really have to look at is previous infectious disease cases. And the two notable ones are tuberculosis, which obviously those cases are old, and HIV. And what the guidance there, what those cases really say is if someone's been exposed to an occupational disease, meaning it's a natural occurrence at the workplace, for instance, if you're a healthcare provider working at a healthcare entity, or if you're a non-clinical person, but you've been exposed at a hospital or physician's office, you're more likely to be able to get workers' compensation for COVID-related illness. Whereas Sal and I just working in a law office, if one of us catches it and the other one gets it, we're less likely to be able to collect workers' compensation. So those are just a few of the sort of hot topics that we're being asked about this week. But if there's any other questions, obviously we're available for those as well.
Great, thank you very much. Dan, what's happening at your practice?
Not much. All of these questions that are being asked today, our practices, taking into consideration. Initially there was some furloughs that were made, pretty rapidly when all of our elective surgeries got canceled, and Dr. Gold, Dan Gold, mentioning all the things that his practice is going through, we're going through as well. We also did not. We're not seeing new patients via telehealth. So our practice is open for emergent cases and new patients that are very, very urgent, any, kind of neurologic problems, deficits, weakness. But otherwise, we have implemented telemedicine. I've been doing a lot of visits, just with established patients. And I think these questions about, bringing employees back are very key and crucial ones that every practice is asking, because I'm sure a lot of practices took the same step. One thing that I touched on last podcast that I think that even if you're a proceduralist, telemedicine, if you still haven't picked it up or you're reluctant to do it, I still think it's very important in keeping your pipeline full. So I know that the patients may not be really enthusiastic about coming back to even do elective surgery in the hospital, get that elective surgery, but you can still counsel them. I'm doing a lot of imaging review. I don't know how much Dan, you order like head CTs or neck CTs, but I'm ordering a lot of MRIs right now and getting them through that workup and reviewing MRIs on Zoom, like this call. And I flip the screen and I show them the MRI and I review with them, and then I counsel them on the actual surgery, talk about risks and benefits. So all that is done so that they can sit here and kind of think about whether they're going to have surgery or not. And down the line, all that backlog of cases will be there for us. So I really encourage even proceduralists to take advantage of the telehealth to try to continue to fill that pipeline.
Okay. Mr. Shu, any new activity otherwise that you want to mention?
Well, as Sal said, individuals who file the applications or successfully file the applications with their lender doesn't necessarily mean that they're going to see the money right away. There's a significant tie-up, and basically banks are putting out those loans by the SBA lenders, which have to get approval to flow back to the bank before you get funded. So it could be a rather long process on a PPA. As far as the other end, there are some other loan activities through the SBA, and the situation is similar. Things seem to be backed up. Government says the money is there, but accessing it is real difficult. If you want to have some direction on either of the two primary loan programs, up on the MSSNY website, we have direct links to all of that information, and the applications are there also. So you could go right there and pull them down and start the application process. Thank you.
Thanks, Phil. Anybody else have anything else for the good of medical practice in New York State and the United States? Well, the good news in New York is the curve is bending. We are starting to see a decline in deaths and I believe a net egress actually today from the hospital system overall. So I think we got to the wall and didn't have to quite go through it. So we're thankful for that. The bad news is, we still have sort of this indefinite reopening. And, optimistically, we're hoping that particularly my specialty colleagues can get back to work more fully on May 1st, but we don't know that. So again, I think we need to really be careful about how we proceed and use some of these programs to sustain us if we need to a little bit longer, if we get into, June and things like that. So I want to thank everybody for joining us today. Dan Choi, any final comments?
No, this has been very helpful. I thank every one of you for being on here and the time that you're spending to share your knowledge and expertise to our physicians. So thank you so much.
Great. Thanks again, everybody.
Thank you for having us.
Good night.
Thank you. Have a great night.
Take care.
Thank you.